Good morning, everyone. It is my pleasure to welcome you to the Tomás Silber lectureship. I have had the pleasure of knowing Tomás for 2 decades, 2+ decades, and he is one of those physicians that has so much gravitas, stature, and authority among adolescent medicine docs, and specifically, but certainly generally here at Children's National. Tomás is celebrating this year his 50th year as a physician. He recently sent me an email. Well-deserved, well-deserved. He recently sent me an email of a presentation that he was giving, and his co-presenters were no other than his 3 adult children. So I'm not sure that I could have kept a straight face if my 3 kids were my co-presenters, but I'm sure it was quite a momentous occasion for him, so congratulations, Tomás. Tomás came to Children's to do a fellowship in adolescent medicine in 1969. He joined the Division of Adolescent Medicine in 1973, and he was the director of the fellowship program until July 2016. For several decades, he's been the go-to consultant on eating disorders, and is currently the medical director of the Donald Delaney Eating Disorders Program. The families that he treated understood that there was a great need for medical education, and they have shown their appreciation by establishing the Silber Lecture on Eating Disorders. We're really honored this morning to have, as our Silber lecturer today, Dr. Jennifer Gaudiani. She's Medical Director of the Acute Center for Eating Disorders at the Denver Health Medical Center. She's Associate Professor of Medicine at the University of Colorado. Dr. Gaudiani did her undergraduate degree at Harvard College, her medical school at Boston University School of Medicine, and her internship and residency and chief residency at the Department of Internal Medicine at Yale New Haven Hospital. She's a member of the AOA Honor Medical Society. Dr. Gaudiani is a certified eating disorder specialist, one of only 2 internists in the United States with this certification. She's already published around 36 peer-reviewed articles relating to her work with severely ill patients with eating disorders. Her current research involves serum markers in patients with severe anorexia nervosa, and she's co-investigator in an international study on assertively refeeding medically compromised patients with anorexia nervosa, an assessment of revised refeeding protocols. She's a devoted teacher, is the recipient of many awards, including the Golden Stethoscope Award, an induction into the Yale School of Medicine Society of Distinguished Teachers. She's become known nationally and internationally as a leader in the field of medical complications of eating disorders. Please join me in welcoming Dr. Gaudiani. Her presentation today will be entitled Medical Complications of Eating Disorders. Welcome. Bienvenida.
Gracias. Thank you for that lovely introduction. And my heartfelt thanks to Dr. Silber for giving me the honor of being here today. Let me briefly mic check. Can you guys all hear me okay? Wonderful. I want to start today's lecture on a sober and honoring note. Dr. Silber and I not only had the pleasure of getting to speak together a number of years ago, but most importantly to both of us, we've taken care of a particular patient together. He when she was younger, and I just in the last few months. He and I would like to dedicate this morning's lecture to Caitlin Funk, who at 21 just lost her life to anorexia this weekend. And I believe that her mother is going to be present here today. This is something that brings home why we do this. This is why Dr. Silber and I, and why many of you do this work. I take care of patients in the top medical stabilization center in the country for adults because, unfortunately, adult physicians don't get any training in eating disorders whatsoever. Unlike you all, I got 0 hours through my entire training. So I'm going to bring to you my knowledge of the patients who start where your patients finish. I see 17-year-olds and up. And we're going to really talk through not just how to diagnose, how to treat, but how to talk about it. Because it turns out that the moment of communication is one of the most therapeutic things that we can do as physicians. It's probably one of the things that got many of you into this business. I have no financial disclosures to report. I want to start by saying that I have happy ties with DC. 10 years ago, just out of my chief residency, my husband and I and our then baby girl moved to DC for a year because my husband became a clerk for Justice Souter on the Supreme Court. So this is my husband chasing our daughter down the halls of the Supreme Court. There's Chief Justice Roberts with a beer, and my husband and daughter and Souter. Patients with eating disorders fall through the cracks medically. And they're some of the patients that you would want least to fall through the cracks because they're such remarkable people. They're so sensitive. They're so brilliant. They're so self-directed. And when they get this life-threatening mental and physical illness that carries the highest mortality rate of any DSM-5 diagnosis, you'd want them to be absolutely surrounded and taken care of by physicians, mental health professionals, RDs alike. And typically there aren't physicians, at least when you get to the adult world, because they're considered too mentally ill for us internists. You know, they resist food. They don't want to do this. And then eventually they get too medically compromised for the mental health professionals, and so they fall through the cracks. As I said, acute takes care of adults, and I just want to let you know briefly what we aim to do on acute, because we take patients from around the United States, often by air ambulance, and with a multidisciplinary team over the course of about 2 to 3 weeks, we provide what we think of as definitive medical stabilization before assisting patients on to inpatient and residential mental health programs. To leave acute, patients are consuming 2,500 to 3,500 oral calories a day, sufficient to be gaining 2 to 3 pounds of non-edematous weight weekly. Their labs are normal or normalizing. They've completed the Refeeding Syndrome. Their bowels are working, they have minimal edema, and they're physically strong enough to move on to the next level of care. Now, so much data shows that with really great early care, which all of you guys are going to be involved in, patients get better. However, the statistics remain somewhat grim. It's important to know that patients who stay in treatment until at least a BMI of 18 have substantially better remission rates. That in a 200-patient study out of Uppsala, Sweden, patients who get as low as a BMI of 10.5 have a 45 times death risk compared to their age-matched peers. And the average body mass index on admission at acute is 12.5 kilograms per meter squared. Almost all the studies show that between 6 and 10 times mortality occurs in anorexia nervosa compared with age-matched peers. And ultimately, that without medical expertise, in this case adolescent medicine and pediatric expertise, there can be a high in-hospital mortality. Psych wards are not good for really critically medically ill eating disorder patients. So in the big picture, and I say this both to people when I speak and I talk to families about this as well, what happens when you starve? I like to think of the cave girl brain. And because neuroscience was one of the classes in med school I almost failed, that is as detailed as we're getting today on the brain. Your cave girl brain kicks in to save you. Your metabolism slows way down. Your risk instinct rises. Patients get very, very anxious and fearful when they're starved. The starved brain is something that Dr. Silber and I see all the time. Lunch is terrifying. A change of venue is terrifying. And it's not the patient. It's not her eating disorder. It's often her starved brain that escalates that sense of enormous risk. Growth and reproductive systems halt, and the body sustains essentials only. And it's important to have this framework as we think about the individual organ systems that malfunction in eating disorders, because when we understand that the body is simply trying to spare every calorie to sustain life, the complications that we see make more sense. The good news is that almost all medical complications will resolve with full weight restoration. And we're not talking about asymptotically approaching approximately 10 pounds below where everyone says you should be. We mean full weight restoration. So my format today will be a case vignette, some definition of terms, an overview of pathophys and of treatment strategies. We'll mention the literature, and then I really want to use it. That's become a great passion of mine. Our first vignette is a 16-year-old male with restrictive anorexia and a BMI of 16.5, who really has few physical symptoms of his eating disorder, and he's admitted to a residential program. And he immediately feels very guilty on admission because he's looked online, he knows he's not the thinnest dude around, and he feels like he shouldn't be there, he's not sick enough. A few days into treatment, he has some pretty significant edema, and he feels generally weak. So they send him to the ED where his FOS is only 1.5, and we're talking about refeeding syndrome here. So the first, we want to talk about the fine problem. Fine is the four-letter F word in our business. All of our patients believe that they're fine. It's part of what I like to call, as an Italian, I have to use my hands, the anorexia goggles. The anorexia goggles are what patients put on because they may be the most brilliant, most insightful, incredible people who are getting a 4.0 and they're the star employee at their job. But when it comes to food and body, they're distorted and they can't see the reality. So when patients are pure restrictors, their labs are often fine. They may be fine until the day they don't wake up. And this is something that I have to constantly tell medical directors of insurance companies when I say, hey, I really need to admit this patient, she's got a BMI of 13, and he goes, but her labs are fine. Well, yeah, because if you're not throwing up, if you're not purging, your body remains often in equilibrium. The refeeding syndrome, as many of you know, is a potentially deadly syndrome that occurs when people start to take in nutrition. We learned about it during World War II, when concentration camp survivors were liberated and fed, and then tragically a bunch of people died. They didn't know why, but it turned out it was from hypophosphatemic cardiac arrest. We learned about it as well when TPN was discovered and people with severe burns were suddenly given nutrition. Refeeding syndrome is fundamentally a problem of phosphorus. There are a couple of ways that phosphorus go low. One, insulin pushes it from the serum into cells, and two, cells use phosphorus in ATP and 2,3-DPG. They use it for cellular respiration and function. Edema happens in refeeding because of an insulin effect as well. Insulin causes retention of salt and water in the renal tubule, as you've seen in many other situations, especially with diabetics, and it goes away with time. A study that we published showed that if a patient has a low albumin at the time of admission, and we'll talk about low albumin later, it gives them a 4 times risk of refeeding edema, not surprisingly, because they just have that lower oncotic pressure. Refeeding syndrome gets really serious if you don't know to look for the FOS. If you're watching the phosphorus daily, you can replace it, and the patient never enters the full-blown refeeding syndrome. The full-blown refeeding syndrome is catastrophic. It can cause rhabdo, other cell breakdown. It can cause seizure, cardiac arrest. But as long as you're watching for it, you're fine. So at Acute, we start calories, and again, this isn't an adult population, although we start at 17, at 1,400 a day. We increase by 400 to 500 calories every 3 days. We do oral nutrition because we have the staffing that allows for that, but we can use tubes if needed. We have intensive one-to-one dietitian support, and we're watching the FOS regularly. Now, the adolescent literature would suggest that starting calories substantially higher than this is both safe and reasonable. We used to think start low, go slow. That was sort of how all of us were trained when we thought about refeeding somebody. It turns out that the underfeeding syndrome may be as significant as the risks of refeeding syndrome. So as long as you're watching the FOS and you give it back to them, you can start calories substantially higher than all of us were trained. Our next vignette is a 15-year-old girl with significant weight loss through caloric restriction who says, you know, I'm just not hungry anymore. I eat a few bites, I feel full, everyone tells me to listen to my body, so I do, and I stop eating. Now we know that intuitive eating, which is a sort of common concept in the eating disorder world, can be great, but typically not in the acute phase when it fails us miserably, because gastroparesis turns out to be almost universal either in severe underweight or in rapid weight loss. I've taken care of patients who've had gastric bypass surgeries that didn't go well and multiple pounds down, but still at above 100% of their expected body weight, they have severe gastroparesis in addition to the anatomic change of the surgery. Gastroparesis, as you all know, causes early satiety, nausea, bloating, discomfort. Guess how that is interpreted by somebody who already feels that eating is shameful and of concern. Those physical symptoms give them all the reassurance they need that food is not good. It's so universal in underweight and in severe weight loss that you almost never need a gastric emptying study unless something about the presentation concerns you. And the key is, it's not just uncomfortable. It can actually cause a life-threatening illness. Now, the problem is a lot of patients in medically inexpert settings, and I do consulting for programs around the country on the mental health side, they're told, well, this is just your eating disorder. This is your mental illness speaking. Push through. When, in fact, this is a medical barrier. It's our obligation as the medical professionals to remove as many physical barriers out from in front of them as we can in their journey to recovery, because they're going to have enough emotional barriers. Now, acute gastric dilatation can occur. As you guys know, your stomach should be right about here. This was one of my patients whom I did a plain film on just to check how her stool volume was. And I took a look at the plain film version of this CT scan, and I said, holy, she didn't even have symptoms. But as you guys can see, her entire stomach is going from her left upper quadrant down to her hip bone. And so she had to be really rapidly suctioned out. She ended up with a lot of complications. She did not perf, which was very fortunate. But this is an example of what can happen. It's not just, oh, the patient will be more comfortable if you treat her for gastroparesis. It's a situation of this could be life-threatening. So what worsens gastroparesis is a long time underweight, really fast weight loss, and interestingly, high-fiber diets. And the little, oh my goodness, lady is there because, of course, our patients only eat high-fiber diets. The safe foods are the high-fiber ones. They're fresh fruits and vegetables and really complex grains. What helps gastroparesis, and you guys know this again from your general diabetic populations as well, is smaller meals, lower fiber, more of a liquid component, calorie dense. You know, rather than eating 15 bowls of safe foods, how about a nice peanut butter and jelly sandwich? But also, when patients lie on their right side, it sort of tips the pylorus towards gravity, and it can at least help the fluid portion escape as well. Prescription options are really important. Now, they're not without complications, and so we have to balance risk and benefit as we do so often. Metoclopramide at 2.5 milligrams ACHS, fully 30 to 45 minutes prior to meals, should be safe. Watch for tardive dyskinesia, and obviously educate patients about that potential risk. If patients can't tolerate Reglan, erythromycin, ethinyl succinate, which I don't know if you found this here too, is ridiculously expensive right now. It's like $1,000 a month. It's so expensive. But erythroped, 200 milligrams AC can work as well. And a study, interestingly, just came out that showed that azithromycin, 250 milligrams, is equally as effective as EES 3 times a day and has less of an impact on the QTC and fewer GI side effects. However, who really wants to put someone on like long-standing azithro? It's not great. It's not great for the QTC. It's not great for their gut microflora. There's no ideal answer here. Now, constipation is also universal in severe underweight and in rapid weight loss. And again, digestive issues plague our patients so much, and they tend to have a much more sensitive mind-body connection as well. So they're going to feel more in their tummies than somebody who doesn't have an eating disorder. Once again, high-fiber diets worsen constipation when patients are underweight. And long-term laxative abuse appears possibly to permanently damage the colon as well. So in acute, we make an x-ray promise. If patients haven't had a bowel movement that feels like it's been adequate and they're worried and perhaps at home they would now down a couple of laxatives, we just check a plain film and we can show it to them at bedside. Because if they have minimal stool, it's great biofeedback. We can say, hey, that feeling you have in your belly right now that you would normally respond by sort of using an eating disorder behavior, there's no extra poop in there, you're okay. But if they have lots of stool, we certainly use Miralax, we use glycerin suppositories, rarely do we have to use enemas. The next slide is a little bit graphic, but it marks why we don't taper stimulant laxatives, because stimulant laxative abuse is a common purging form in anorexia, binge purge subtype, or in bulimia nervosa. And the fact is that long-term stimulant laxatives ruin the colon. We don't know how. We don't know exactly why. We know that it has something to do with the nerve plexus. And the fact is, some patients can have abused laxatives for 30 years and still have a colon that wriggles, and others can have abused laxatives for 5 years and suddenly they've got an atonic colon, just like the patient who may have smoked for 5 years and now has COPD versus smoked their whole life and attributes that to their longevity. There is a body sensitivity to certain insults that is really prominent in eating disorders. So we never taper stimulant laxatives. You know, I see patients who are taking up to 150 stimulant laxatives daily and spend their entire day with crampy diarrhea. It's not appropriate scientifically or emotionally to taper those. They need to be stopped. The next vignette is an 18-year-old who visits her pediatrician for her routine physical. Doc, everything's great. She's getting straight A's, she's a cross-country runner, and by the way, she is eating super healthy. If she's 5'5" and 95 pounds, and you look back through her chart and you realize she's lost a ton of weight since you last saw her. In addition, her pulse is 35, but she says, oh, don't worry about that. I'm an athlete. I run like 5 miles every day. Don't worry about me. She also notes she's had no period for 7 months, and she'd just like you to put her on the pill just to get her period back. She thinks that it's probably healthier to have a period, and no, she's not sexually active, but she just thinks that would be better. So vital sign abnormalities are really prevalent in eating disorders. And again, it comes back to that cave girl brain thing. She slows everything down. She cools your core temperature. Just like in the winter when you want to save money on your heating bill and you close the vent in a room that you don't use often, she closes down the heat to your guest room, called your hands and your feet, because those aren't really life-saving. So hands and feet are cyanotic. They're incredibly cold. She gives lanugo back to hold in the hair, to hold in the heat. And in addition, the vagal tone rises, just like a bear hibernating in the winter. So blood pressure goes low, heart rate goes low, spare calories. Here's the difference, though, between somebody who's an athlete and has resting bradycardia and somebody who has anorexia and has bradycardia. And I call it the walk across the room test. If one of our patients with anorexia is asked to rise and walk across the room and back, almost invariably her pulse is going to double, triple, or quadruple. The most extreme example of this that I've seen is a patient that I had who, when she was 18, had a resting pulse of 20 with variable block, and when she got up to brush her teeth, it went up to 180. So what this is a starved person's heart. The heart rate is low because of high vagal tone at rest to spare calories, but because she's lost skeletal muscle, getting up to move through space, her heart has to go like a little hummingbird to just get the body what it needs. And heart mass also decreases in anorexia. So when somebody is saying, oh, doc, it's just my athletic heart, you say, you know, Lance Armstrong, pre-roids, when he had a resting heart rate of 35, it was 35 when he sat, it was 35 when he skipped, it was 35 when he walked down the hall. That's an athlete's heart. Your heart rising so fast when you get up and move around, that's a starving person's heart. And we proved this sort of, well, we sort of proved this vagal tone concept because we had a 31-year-old patient who admitted to us with junctional bradycardia, no P wave. About a week and a half into refeeding, she had a junctional tachycardia, no P wave, narrow, complex, pulse around 80, and we were a little nervous then. We were like, hey, where's that P wave? And so we thought, she's doing okay right now. Let's give her best day ever in treatment and put her on a treadmill. Let's give her a little adrenergic tone. And indeed, 3 minutes into exercise, her P wave came back. And then 3 minutes into rest, her P wave went away again. And after another week and a half of refeeding, she had sinus rhythm again, and she was absolutely fine. So in her case, she just had a really, really high vagal response to her starved state, and that's why she was in a junctional rhythm. And we published this in cardiology. The amenorrhea part refers to the fact that patients go back in time in their hypothalamus. They go back to pre-puberty. Amenorrhea is a sign of a chronic imbalance between exertion and caloric intake. And the combination of no estrogen plus really high cortisol equals not a safe time to have a baby, so everything shuts down. This is the same thing for guys. Their testosterone falls. problem here is several, but one of the main ones is that bone density falls early and fast. Unfortunately, the prevalence of osteopenia and osteoporosis in adolescents and adults with eating disorders is really high, and it's the one medical complication that may never get all the way better. The gold standard for treatment is full weight restoration. However, there are some potential pharmacologic agents, and again, I own no stock in any of them. So bisphosphonates have now been evidence-based out of a Harvard study from 2011, not in patients as severely ill as the ones that I see. And Forteo, which is anabolic, actually showed even better results in an adult population than the bisphosphonates. Bisphosphonates have some problems. You know, they cross the placenta, they stay in your body a long time. Animal studies show harm, not optimal, but again, not something that you guys will be seeing as pediatricians and adolescent medicine docs. As far as her request for estrogen, doc, just put me on the pill, give me a period. There's no evidence for this. There may be some evidence in adolescents for patch estrogen, and that's just starting to emerge. But as far as giving the pill to make a period happen, it has no impact on the bones. And unfortunately, it's still all too common in community doctors to say, oh, she's amenorrheic for a while, let's give her the pill to regulate her. That doesn't regulate anyone. Every girl with a uterus gets a period on the pill. It's not a sophisticated understanding of what's really going on, and it actually can contribute to denial of disease. Because if she's getting a period every month, she sort of thinks, well, I guess I'm normal. I guess everything's okay. And what about exercise? Because our patients really like to exercise. And I've had many patients say, Dr. G, you know, I should probably be like doing more while I'm in the hospital because everyone knows that exercise helps your bone density. Well, exercise helps my bone density. But when you're underweight, a really useful study out of Canada showed that when patients were still underweight and not menstruating, even moderate exercise, which included pacing, worsened bone density, which sort of teleologically makes sense in the sense that if you're underweight and you don't have enough body resources, if you still push your body, you're going to suck more resources out of it. However, for the once and future athletes among us, once patients had fully restored their body weight, even intense exercise helped. And so what I tell my patients is serious exercise is a privilege of recovery. And that's really important because you have to use every possible motivator you can to help break through that desire, no, I got to stay in my eating disorder, this is too scary. No, like you're an athlete, you can do this. Once you get back up to a healthy body weight, you can do this thing you love and are good at again. And the fact is that as far as some of the dysfunctions of underweight, muscle weakness is really common. You know, excessive exercise, especially when you're starving, does not tone muscles. It does not make, like, long, lean muscles. It just shrinks them. Our patients exercise off all of their lean skeletal muscle. And, of course, I have patients who are so sick they can't even lift their head off the pillow. Although I also have patients, you know, extraordinarily, I just took care of a 35-year-old woman with the most severe case of kyphoscoliosis I've ever seen. She had lost 5 inches in height, and she bottomed out at 37 pounds, and she traveled by commercial air to me. So patients are extraordinary. Now, what about high-risk athletes? So this young woman in your office is telling you she's a great athlete. Really good athletes should have super normal bone density because they're using their bodies. They're putting that electrical stimulation on their bone to say, hey, thicken up, we need you. So I would say, in the case of the young lady in your office, check a bone density scan. If she has a bone density that's even less than +1, and she's amenorrheic and she's lost 20 pounds from where she should be, you have to sit and say, things aren't okay. We're not going to wave this one off with a prescription for the pill and say, see you next year. We're going to say, hey, your body is not fine. And she might say, but that's ridiculous. That's not fair. I have a friend who's got exactly the same body as I do, and she's fine, and she's running really well right now. You say, hey, I'm individualizing care to your particular situation. and your body is telling me that it's not okay because you have low bone density as a result of what you're doing. So something has to change. And you guys are often going to be the advocates with parents, with coaches, with other practitioners in the community. You have to be the place where the buck stops, because the faster you can engage this young person in treatment, the more likely she is to do well long term. And there's a terrific, groundbreaking article that I have the author's permission to use tables from, which actually gives a return to play scorecard. Who doesn't like a nice scorecard? And this goes over risk factors that include low energy availability, BMI, age of menarche, presence of a stress fracture, and it gives each a low, medium, or high risk point system. You then use the points accrued to say they're fully cleared for exercise, they're limitedly cleared, or they may not play. And this is evidence-based work. It's a really, really great article. The next vignette is a 19-year-old college freshman who has a quickly falling weight, presents to her doctor's office visit with her parents. The only lab abnormality that they discover is Pancytopenia. And out of that office visit, the patient comes away thinking she's fine. The parents come away thinking it's time to go to the oncologist and make sure she doesn't have cancer, and no one mentions an eating disorder. It turns out that Pancytopenia is not uncommon, or at least 1 to 3 cell lines diminished. And the reason is because of something called gelatinous marrow transformation, or serous fat atrophy. Essentially, the bone marrow gets so starved that it stops making cells. It just is replaced by an acellular goo. You don't need a bone marrow biopsy for these patients, but it's a source of incredibly inappropriate workup. I can't tell you how many patients' presentation to an eating disorder treatment was delayed because the patient said, no, I love to eat, it's just I don't know what's wrong, because they were still inside their own head about the disorder. And so a big medical workup was undertaken when you first have to think of common things being common. In a study that we published, we showed that abnormalities and cell lines are really common in our population. The next case would be sort of, there's 2 pieces to it. A more typical one might be a 17-year-old boy with anorexia and a BMI of 16, has an AST of 125 and an ALT of 58. He's a non-drinker, he's not on any hepatotoxic medications, and he has no history of viral hepatitis. What we've seen on acute before would be a 21-year-old with type 1 diabetes who comes in with LFTs in the 4,500 range. So what happens in anorexia is that the liver becomes severely starved and goes through apoptosis. And so LFT abnormalities are extremely common in this situation. Oftentimes, it worsens for the first week of refeeding, and I think of that as the comet tail effect of sort of last week's starvation having its impact. A study that we published shows that an AST or ALT greater than 3 times normal, so call it like the mid-100s, independent of BMI, predicts hypoglycemia. And I'm going to talk to you about why I care so much about hypoglycemia. More rarely and less seriously, weeks in, you can get a little refeeding steatohepatitis. Let us not call it fatty liver. That typically would be an AST and ALT in the sort of 50s, 60s. Both of these will go away with time. Starvation hepatitis will go away simply with refeeding as the liver gets recharged, and refeeding steatohepatitis will improve as well. And this brings us to hypoglycemia. So a 16-year-old woman presents to her pediatrician who notes she has a blood glucose of 45. The pediatrician gives her a glucometer, and unfortunately this now becomes her new focus of how low can you go. Here's the deal. Everybody pays attention to cardiac stuff in patients with anorexia. And I'm not exactly sure why. I think it's because the cardiac stuff looks dramatic. I think it's because even we physicians have in our head that, you know, the heart, when the heart stops, it must have been a primary heart problem that caused it to stop. But I have watched for 7.5 years the sickest patients in the country, sickest adults in the country, on telly, and thank God not one of them has just sort of tipped down to 0 or gone into torsades. So I really don't think that young people's hearts just stop. But if they run out of fuel, they'll stop. And I believe that hypoglycemia is the death knell for anorexia nervosa. And now with Caitlin's death, I suspect that we have another reason behind this, but I have lost too many beloved patients who waited or resisted a little too long going back into treatment, went into an inexpert hospital, declined food, blood glucoses weren't checked, and when they sort of finally started to get into the transfer process, they passed away. I have a young man who cored in an airport, and his blood glucose was 0 when EMS checked him. I have a young woman who came to us by air ambulance after having resisted in an outside hospital for a week, and she PEA arrested, and her blood glucose was 0. This is the sort of pre-morbid finding. And the problem is a lot of my patients don't have symptoms because they're not connected with sort of your body is suffering. They kind of soldier forward and they say, I'm fine. You know, I had a young woman fall at an airport and break her hip and get on the plane and travel to me with a broken hip. They are so tough. They are suffering so much, but they are so tough. So doctors may say, and I've had questions before, well, it's not a big deal if they're not symptomatic, right? It doesn't matter whether you're symptomatic from a blood glucose of 30. I've had patients present to me with a blood glucose of 11, pacing like a tiger in the room and saying, I don't want juice, I don't want juice. It does not matter whether they're symptomatic or not, but pretty soon their brain will be damaged or their heart will stop. And so I think we all need to pay a lot more attention to blood glucoses. In underweight, of course, the hypoglycemia arises because our livers are very kindly making us glucose when we're between meals. But when you're profoundly starved, you lack the gluconeogenic building blocks and the glycogen to create sugar. And the longest fast of all is typically overnight. And I think that that's why we see so many cases of patients not waking up in the morning. So on acute, we check blood sugars every 4 hours until they're all over 60. You can use D5 normal at a slow rate if the patient obviously is profoundly low and you need in the moment to save them. But of course, D5 is going to give you an insulin bump, which is going to drive your FOS into your cells, and so you may have trouble with D5. So we often use a little Ensure or milk, even better, every couple of hours to sort of reboot their livers until they've had enough food to recharge the liver stores. The next vignette is a 19-year-old woman with Binge Purge anorexia who resists going back into treatment. Now, anorexia comes in 2 flavors. If you're very underweight and meet all of the other medical criteria, mental health criteria, you can either have restrictive anorexia or you can have Binge Purge anorexia. Purging is typically through vomiting, laxative abuse, diuretics, and sometimes thyroid hormone. When this patient goes into emergency departments and gets IV fluids, she's like 10, 15 pounds up within a couple of days. And needless to say, that is not acceptable to her. And it tells her eating disorder, see, we told you this wasn't going to work. You shouldn't be in treatment. Her potassium usually runs in the 2s, and her bicarb runs in the mid to high 30s. So in this case, her potassium is 2.5, her bicarb is in the mid-30s. Once again, she's got a severe contraction metabolic alkalosis from the chronic volume depletion occasioned by her purging. Unlike the restrictors, patients who purge often have dangerously abnormal chemistry values. And so we want to talk about properly managing volume depletion, you know, casually known as dehydration in these patients. I've taken care of an ICU nurse from California who, when she would pull Lasix from the Pyxis, she'd give half of it to her patient and half of it to herself. And just the act of stopping Lasix without any IV fluid would cause her to get such severe rebound edema that she'd get cerebral and pulmonary edema. Needless to say, that was a massive impediment to her proceeding in treatment because she would get so dangerously ill. So what's going on? We go back to our cave girl brain. Your brain assesses correctly that you're dying of volume depletion and says, if we're so lucky as to come upon an oasis in this desert where there's salt and water, we'd better have upregulated any hormone that we can so that we don't pee away those life-saving resources. And that's exactly what your clever body does. Your adrenal glands overproduce aldosterone, and you end up with a secondary hyperaldosteronism called pseudo-Bartter syndrome. As a result of pseudo-Bartter syndrome, you hold on to every drop of salt and water you take in, but you also pee away potassium. So all of these patients who are trying to be given potassium in the community for their purging and their hypokalemia, they're just peeing it away. As long as their pseudobarter syndrome is still on, they're peeing it away. So the key points to treat this are to stop purging completely, to give very slow IV fluids. Even in our adult population, we never use faster than 50 cc's an hour of normal saline. And then, of course, to block the overproduction of hormone with spironolactone. This really works. This is a great way to establish trust with patients because they didn't think it was possible before. And now they see that they can actually have minimal edema when they refeed. It was really cool. When I was doing a speaking tour in Australia, I spoke in Brisbane, and they had it WebExed into their satellite places because, of course, Australia is pretty spread out. And I found out just the following week in a big conference in Melbourne that in one of their, remote outposts, a woman had come in with severe purging, and that the dietitian who had been watching the presentation, jumped on it, and she's like, I know how to fix this. And so it's a really nice intervention. Low potassium typically does not occur with restricting alone. If somebody's running hypokalemic, they are probably purging. And potassium pills, as we know, cause GI upset, so better to fix the pseudobarter syndrome than just to give them a gastric ulcer with lots and lots of potassium, because a dehydrated patient will just keep dumping their K. A note on type 1 diabetics and edema. I regard my patients who are deliberately underusing their insulin in the towards the means of their eating disorder as having pseudobarter syndrome and purging physiology, even if they've never thrown up in their life. Because essentially, they've got a hyperglycemic, osmotic diuresis going on all the time. So it's like they're abusing Lasix. You guys may not know this, but in type 1 diabetics, there is a 20% incidence in the general population of people deliberately misusing their insulin in order to lose weight. Because as soon as you don't give yourself insulin, you're functionally starving your cells and you're using a diuretic. And so it's an amazingly high percentage, and the sum total of the mortality rates of type 1 diabetes and an eating disorder are way more than if you just sum up the two different mortality rates. It's a very serious problem. So I use IV fluids and spironolactone in a similar way with my type 1 diabetics. Now we're going to leave time for questions at the end of this. This is one of my favorite slides. The title of this slide is, Know When Your Ass is Overwhelmed. So having been through medical training, I want to remind all of you to take care of yourselves as well. It's very, very important to take care of yourselves and to take care of each other. My patients teach me this all the time because they are some of the most driven, remarkable people you could ever ask to see. They study so hard, they work so hard, they want to do so well, but they have such trouble sitting back, putting their feet up and saying, I've done enough today. It's okay to rest now. And I don't know if any of you ever deal with that little problem as well, but I do. It's so important for us to take care of ourselves as whole people. And so I just, take this public service announcement to remind you all that you don't get to rest conditionally. It's not after all of the check boxes are checked that you say, all right, I'm good. I can put my feet up now. Just like you can't say, well, I'm going to do everything I need to do today, and then I'm going to breathe. It has to be integrated into the rest of your day. One of the things that's really exciting that I have Denver Health's blessing to share with you is that after 8 great years at Acute, I'm going to go into private practice and open my own outpatient clinic this fall, which will be the Gaudiani clinic. That'll be the first adult internal medicine clinic in the country dedicated to adults with eating disorders of all shapes and sizes. I miss knowing my patients over years. It's hard to fall in love with them for a week of really intense time and only see them in their sickest, saddest place. And so I'm going to go back into the outpatient setting and take care of patients from Colorado and around the country. I am now very, very happy to take questions, and I thank you so very much for letting me be here.
Well, thank you very much, Jennifer. Is this fun? In hearing your presentation, I'm reminded of Osler's dictum which was "He who knows syphilis knows medicine," and I think we can now switch it to "He who knows eating disorders knows medicine," and you've shown that. I have a question for you because I'm very interested in the study that you have done on biological markers for anorexia. If you could tell us a little bit about that study.
Yeah, I wish that I could tell you something sexier or cooler about it, frankly. We're still looking for interesting biomarkers that help us know severity of illness, that help us predict elements that aren't otherwise obvious from a macrophysiologic perspective. We've looked at complement levels in patients, and it turns out they're extremely low. These patients are not inflamed. And I think I didn't mention, but one of the reasons we can see this is that my patients' albumin levels are almost universally normal. And you say, no, stop. How is that possible? Because we all know that albumin is a marker of malnutrition. Albumin is a marker of the underlying disease process that is inflammatory, malignant, rheumatologic, or infectious that causes a non-eating disorder person to become malnourished. But in my patients who were not inflamed at all, their albumins are perfectly normal. So we use it as a canary in the coal mine. If somebody's albumin goes from 4 to 2.5 one day, we say, okay, we've got an aspiration pneumonia brewing, we've got a UTI brewing, let's look at her skin, what's going on. So we looked at complement levels. We looked at thromboelastograms to say, this is used in mid-operation for patients who are getting transplant surgeries to look at their coagulation profile. These patients are very, very low coagulable. They do not form DVTs. We don't put them on heparin prophylaxis. We've looked at prealbumin, which is a really interesting marker. Our prealbumin study in IJED with the International Journal of Eating Disorders was the first study to look at the value of prealbumin in adults with critical anorexia. And we actually found that low prealbumin levels below 18 to 20, independent of BMI, predicted hypophosphatemia and hypoglycemia at 2 to 3 times baseline. So that's maybe interesting. It hasn't been validated in kids or in other populations. And we're just starting to do some work towards blending the concept of biomarkers and neurocognitive function. Our psychologist and one of our attendings, who's a med psych attending, just got their first R21 grant to look at some really detailed neurocognitive studies blended with biomarkers. We're fascinated by the idea of what's going on in the microbiome. So we had some scientists from UNC Chapel Hill come out to us the other day. This is a nascent field, but it's totally the cool kid sandbox right now. What is it about our gut flora that impacts our overall health? And unfortunately, because this is early days, there's some hooey science out there right now about it. So we have to kind of move through that and really understand how the microflora is impacting patients. But a great example of a study that the folks at UNC Chapel Hill have done is they took patients' stool from the time they arrived at UNC Chapel Hill when they're starved and have a very slow metabolism. So it would be expected to have microflora, perhaps, that could really extract nutrients effectively. And then they took stool from patients who were 6 weeks out, well into refeeding, hypermetabolic as can be. These patients need 3,500, 4,000 calories a day to restore weight. And they put those 2 different stool samples into 2 different populations of non-bacteria mice. And then they fed them the same meals. And fascinatingly, just based on the different microflora, the mice that had the stool from time 0 gained way more weight on the same calorie plan than the mice who had the sort of hypermetabolic bacteria. So that's so interesting. What are the implications? Is there like a get thin or gain weight, powder you can take? Absolutely not. We're colonized. It's not like there's a place in our guts just waiting for us to, take a good probiotic and that will be healthy. But the really interesting early signs of kind of how our gut flora interacts with the way that we work. So those would be some of the answers for you, Dr. Silber. Other questions?
So do you have you showed some great vignettes and about the subspecialist, that someone shows up in their room, and this happens a lot. and you mentioned the pancytopenia, you mentioned it's not orthostasis, it's, tachycardia. I'm a cardiologist. So, folks are coming in to cardiology, and the last thing in the world they're expecting you to say to this kind of teenager who's amenorrheic, weights just underneath where it's healthy, and you point out some of those things. Can you give some ideas to the subspecialist where they're coming for tachycardia, they're coming for these things, and they don't have heart problems, but you suspect it? Other than mentioning unhealthy weight and commenting to the pediatrician, what is the subspecialist when you see someone that isn't labeled as an eating disorder?
What a fantastic question. Thank you so much. That's really thoughtful. I think subspecialists are at a real disadvantage in this situation because you have limited time and you have a patient and possibly a family who's resistant to hearing the message you suspect needs to be given. However, you are vital. You're vital, and obviously you're fortunate to have some of the greatest resources in the country in your backyard and as your colleagues here. So I would say that just as it's our job to speak truth to patients, for instance, at the end of life with critical cardiomyopathy, and you say, here are the things I'm not going to offer because they're not going to work. And I can't offer you a menu of, here's a set of equal possible interventions that I could now give you. No, you have to say, here are the things that are going to work, and here are the things that aren't. You have a similar obligation if you are among the folks who actually know and care about this disease to say, there is no reason to believe that you have a native dysrhythmia that's causing your problems. I think this is underweight mediated. And now that I've had you sit and now walk across the room and back, I'm further convinced of it. So I'm not going to clear you to go to track this year. I'm very concerned. We got to stop everything. And the parents may say, well, how dare you? What are you talking about? But the fact is, you may be the one that then saves the patient because the doctor has so much authority. So for the few subspecialists who actually know the medical complications of anorexia, you have a power to potentially save a life, and not just save somebody to survive, but save the months and years in which they live behind a fog. So many of my patients are like, well, my cardiologist just told me that I was an athlete and I'm fine, because they want to hear I'm fine, I'm fine, I'm fine, I'm fine. But if you say, I don't know, but you need to put on the weight that I've noticed you've lost and then come back and see me, and if they say, well, how dare you, I certainly don't want to do that, then you're further reinforced. But the appropriate trial of therapy is, let's see how you do when you're more nutritionally restored. And I think working as a multidisciplinary team is so vital with great communication. Yes.
Hi, I'm sorry I didn't get to meet you earlier. I'm Larry DAngelo. I'm Dr. Silber's partner for the past 34 years.
Oh, wonderful.
And I'm an internist.
Oh,
so a couple things. First of all, Dr. Martin, in response to your question, your group has actually had a great positive influence in referring patients to us. We've had a couple patients referred for bradycardia, and actually someone was turned away from cardiology who had been referred to you for a pacemaker insertion.
Yes.
An outside cardiologist.
More hamburgers.
You sent them someone sent them directly downstairs to us. And this young man was saved a pacemaker insertion at age 15. Unfortunately, there was likewise a prominent cardiologist in the community actually cleared an athlete with a BMI of 13 who was a cross-country runner because, quotes, her heart rate of 38 was consistent with the fact that she was an athlete. I actually do have a question. We have a number of our patients who actually present with hepatomegaly. Significant hepatomegaly, liver size in the 12 to 14 range. We've told them pretty consistently that we thought that this was, using the analogy of type 2 diabetes and using the analogy of some of the early starvation studies out of the concentration camps, that this was potentially a steatohepatitis. But what you've told us today is that steatohepatitis occurs rather as a complication. Then why do these people, inconsistent with those other two studies, not have a steatohepatitis?
Great question. I've seen hepatomegaly too without the echogenicity of steatohepatitis, and I do not know the answer. I think that it's probably worthwhile for somebody to do reticuloquadrant ultrasounds on all of these patients, and you know, the problem is that once you do a biopsy, you're getting invasive, and no coma is going to say okay to that. But we don't know, and I've seen it too, and we don't know the answer. It's a great question.
I'm curious. To what extent is anorexia a product of our modern images of attractiveness, and is it seen in societies without those images, say with the Inuit Indians or Native Americans or so on? And if that's the case, what are preventive and screening strategies that might head it off earlier?
It's a fabulous question that I'm passionate about. So a few answers to you. One, we think of anorexia nervosa and eating disorders as being a typical environment loads, genetics loads the gun, environment pulls the trigger. And I wasn't sure how I could quite understand that in an eating disorder model, because obviously our genes haven't suddenly changed over the last couple of generations as this seems to have become more prevalent. But when you understand it through, for instance, the more familiar lens of alcoholism, Native Americans have a higher propensity to alcoholism genetically, but until there was alcohol in their environment, there was no disease. But once there was alcohol in the environment, suddenly there was a huge preponderance. Throughout history, there have been people who are on this side of the spectrum of perfectionistic, anxious, goal-oriented, and intense. Many people in this room would probably fall on this side of that spectrum. But probably never before in history have we been so subsumed by images of thinness, fat phobia, clean eating, bullshit, you know, all of this stuff. And so I think that it probably does begin to set fire to some of those genes, is my sense. You know, Dr. Silber and I were talking last night about whether this is really growing in its prevalence or not. We don't know. Certainly people are more aware of it. It does run in families. That's the genetic temperamental piece that gets handed down. But through history, there have been sort of nuns and the like that become saints that sort of have this wasting disease. And this has been described certainly through history. As far as native populations who have different ideals of beauty, there was a fascinating study that came out of Fiji that Ann Becker, I believe, did. And so she observed the population of Fijians before they had TV, and they have a much more rounded, beautiful feminine figure as the goal of beauty. And a lot of really deep cultural underpinnings for staying well fed, because the risk there is malnutrition. 3 years after TV came to Fiji, she went back and did more observations of body image. And there were sort of 3 channels, and one of them was like a New Zealand soap opera. And suddenly, 15+% of girls were throwing up to lose weight. And a bunch of women said that they felt like they were too heavy. She did a subsequent study that identified the idea of secondary media exposure. And it turned out, as she did quite rigorous evaluation, that it wasn't how much TV your kid watched. It was how much TV her friends watched that predicted whether or not you would get disordered eating. So unfortunately, there clearly is, and it's not as if they thought necessarily that the women on the TV were beautiful. It's that these very different looking people seemed to have extraordinary lives that were unimaginable, and so perhaps that was the body that you needed to get those privileges.
Thank you very much. For those that would like to continue the dialogue, we are having a little coffee in the medical education room. You can come and join us. And at 11, Dr. Gaudiani is going to do psychiatric grand rounds addressing mimics of psychiatric syndromes caused by medical complications.
Thank you.